Hi, I'm Allie Shansfeld, Managing Editor of Endodontic Practice US, a MedMark publication. Welcome to a live presentation and question and answer with Dr. Jon Irelan. In our webinar today, we will be exploring advancements made in the understanding and execution of endodontic apical microsurgery, as well as the positive impact these advancements have made on treatment outcome. Before we get started, I want to invite viewers to use the question box in your control panel to ask any questions, and your questions will be answered at the end of the session. Also associated with this presentation is a free CE quiz. At the end of the webinar, we will email all attendees instructions on how to access the free CE quiz. Our learning objectives for today include to discuss advancements in endodontic apical surgery and its viability in contemporary endodontics, reviewing criteria for case selection and considerations to be made during the treatment planning process, evaluating clinical cases where apical microsurgery has been successfully employed with the aid of radiographs, photographs, and video footage. I'm pleased to introduce our guest for today. Dr. Jon Irelan received his BS and DDS at Marquette University in Milwaukee, Wisconsin, where he was the recipient of the American College of Prosthodontics Outstanding Undergraduate Achievement Award, as well as Hanau's Best of the Best Excellence in Prosthodontics Award. He has earned an MS in prosthodontics from Marquette University, after which he practiced as the sole prosthodontist for a 60-practice dental group. Dr. Irelan later earned a second MS in endodontics from Marquette University. He continues as an adjunct assistant professor of endodontics at his alma mater. Dr. Irelan lectures nationally and internationally on topics including complex treatment planning and advanced restorative procedures, and he has been published in multiple endodontic and prosthodontic journals. Additionally, Dr. Irelan maintains a private practice in Mount Pleasant, Wisconsin. Dr. Irelan, we turn the webinar over to you to learn more about our topic for today.
Thank you for the wonderful introduction, and thank you everybody for joining me for this webinar. So today I'm going to be talking about advancements in endodontic microsurgery. And effectively, I'd like to touch on the advancements that we've made in this particular treatment modality. And then real quickly, I do have a professional relationship with Carl Zeiss Meditech. So what is root end surgery? Root end surgery is simply the removal of the root apex and the adjoining tissues, granulomatous tissue or infectious tissue. And during this process, we may or may not include a retropreparation and retrofill, but the procedure in general has evolved over recent years. So a quick history of root end surgery. In the 1800s, we really began doing this procedure in its infancy. The idea being to address an infection at the apex of a root. This allowed us to avoid the tortuosity and constriction of the endodontic system. And we could go right through the cortical buccal plate, ablate the root end, and remove the lesion. Traditionally, they would actually pack cotton or sponge in addition to a medicament into this abscess or osseous crypt. And the goal was ultimately for the lesion to resolve, though it had a poor success rate. Over the coming years, we began placing a root end preparation. A root end fill would be done subsequently with amalgam or with IRM. And then in the 1990s, we made some major advancements. Root end surgery, traditionally, without the aid of microscopy, had a relatively poor success rate at 19 to 68%. It was kind of viewed as a last-ditch effort to save critically important teeth, teeth involved in major prosthetic reconstruction, etc., that had been treated in the past with endodontic means and a lack of successful resolution of the lesion. With advancements in endodontic microsurgery, we have a much higher success rate. We're looking more at the 86 to 97% rate, and that is a success rate that is comparable to any dental procedure. So what are the major changes that have increased our success rate so markedly? CBCT is one of the many improvements we have made. With CBCT, we can now visualize the tooth or teeth we're interested in, the lesion and the general size and location of that lesion, as well as the surrounding structures. It gives us an opportunity to evaluate the clinical field without an overlap of anatomic structures or superimposition through traditional two-dimensional radiography. And so now we can really measure things very precisely with a minimal amount of radiation, a small field CBCT equivalent to about 2 or 3 periapical films. And so in this particular example, we can see before we even enter into a surgical treatment plan exactly what we're going to run into: unaddressed palatal root. So the beauty about CBCT is, again, we're able to determine exactly what the etiological cause of persistent apical periodontitis might be. We can visualize exactly how much distance we have from the root apex to vascular anatomy, nerve anatomy, etc. We can also determine the general angulation of the root relative to the clinical crown. In the lower picture, we can see that in general, the root is diverging from the clinical crown apically perpendicular to that occlusal table, whereas in the top picture, we're dealing with about a 30-degree angle toward the distal. So it can be very misleading if we're simply going off of two-dimensional radiography or our assumption of where that root anatomy is located. Additionally, when we're treatment planning and we're trying to determine exactly how far in we must make our osteotomy in order to reach that root anatomy, it's critically important. Some people have very thin buccal cortical plate. In certain circumstances, we're going through 15 millimeters of bone. And if we are going further and deeper, we need to know exactly where we have vascular anatomy and nerve anatomy. I don't get too nervous about a 12 millimeter distance through buccal cortical plate to reach the apex of a mandibular molar, as long as I know that that lingual nerve is a good distance past it. And so we get a lot of wonderful information from CBCT in our treatment planning process. It also paints a little bit more of a clear picture. For example, this is a case that has been previously surgerized. We can see that there's a lot going on in the PA on the left-hand side. But when we look at the CBCT, we can see that it has, again, been previously surgerized. It has a traditional key slot preparation where they did not address the palatal aspect of the root, either intentionally or through accident. We have an amalgam retrofill, which has become displaced and is now disseminated into that lesion. With regards to illumination, we're no longer using incandescent bulbs or lighting. We now have LED. In particular, Zeiss does not even offer a xenon bulb, as far as I understand it, anymore. With LED boost, we now have an opportunity to get excellent lighting with a much longer lifespan on the light source. With magnification, we can work in a very constricted osteotomy. It allows us to be very conservative. This is a particular clinical situation, a case that I saw where a patient had been referred for the extraction of this bicuspid due to vertical root fracture. The periodontist thankfully took a CBCT and noted that the lesion was focal to this dilacerated portal of exit toward the mesial of the tooth, and we have a nice periapical radiolucency focal to that portal of exit. It's also important to note that we're quite close to the membrane, the Schneiderian membrane of the maxillary sinus. And so while there's no indication of vertical bone loss that would tell us that this tooth is fractured, and it is surgically treatable, we want to know exactly where that sinus is relative to our apex, and we want to be able to visualize and resect that root apex without violating that maxillary sinus. And if we look in this particular picture of the osteotomy, we're looking right at our Schneiderian membrane. So it really allows us to work in areas that just require a bit of a smaller osteotomy. Magnification plays a critical role, but even from an ergonomic perspective, there are certain features now that some microscopes offer. I have a Zeiss Xtara 300. I really enjoy the foldable tubes, which you can see in this image here. It really improves ergonomics when you're dealing with the chair angle or patient distance. I happen to work with a patient population that typically averages around 60 or 70 years old. So for folks that are unable to lean far back, or I'm trying to get a different angle on a surgical site, I can actually tilt my microscope in without having to lean far forward. I can have the patient sitting up in a comfortable position, and I can perform my procedure without putting myself in a bad position. For patients that have shoulder issues or neck issues, I can't necessarily set them on their side or have them turn their neck for an extended period of time. Mora interface has offered me a lot of flexibility with that, again, sparing my own back and neck while I'm doing the procedure. So magnification on a multitude of levels has offered a lot of flexibility. As far as armamentarium goes, micromirrors have become quite useful. It allows us to use indirect vision in a much smaller osteotomy site, and I'll kind of get into why that is so important for us. Ultrasonics have become key. They effectively replaced endodontic micro drills. We no longer have to do a key slot preparation like you saw in that earlier radiograph. We're now able to retro-prepare into the previously prepared root canal system, and we can go a good distance deeper, which again becomes critically important. And then microsurgical scalpels is simply another means of becoming more conservative with our approach. With regards to the osteotomy, again, we can significantly decrease the diameter and the dimension of that osteotomy, and that's only secondary to illumination and magnification, as well as the use of ultrasonic tips, which offer us a lot more flexibility and freedom. We no longer have to rely on direct vision. Sometimes we luck out and we're able to see directly, but that's not a critical necessity anymore. So then getting back to the benefits of indirect vision, it really ties into the root end bevel design. One of the shortcomings in traditional endodontic surgery, macroscopic surgery, was the necessity for direct visualization of the root end preparation. That typically meant that we had to incorporate a 45 to 60 degree bevel. And while that allowed us to see the root apex and to evaluate it directly, it would oftentimes result in an incomplete resection of the 3 apical millimeters of the root apex. And that's critically important because we know that that's where the majority of canal aberrations and ramifications are going to be present. By resecting at a deep angle, it also exposed a lot of dentinal tubules unnecessarily. These dentinal tubules could house bacteria and necrotic tissue, and so we could wind up in a situation where ultimately we're releasing more noxious substances into the periradicular tissues. By adjusting to a 0 to 10 degree, we're again resecting that root apex appropriately, and we're not exposing those dentinal tubules to the surrounding tissues. With regards to the root end preparation, it's particularly useful in premolars and molars in general, because we're now able to prepare deeper than 1 millimeter. We can prepare 3 millimeters in depth, which gives us an additional margin of safety after that root end resection. And it's quite useful in situations where we're dealing with a limited amount of root length and resecting 3 millimeters isn't necessarily a possibility. It still allows us to clean and shape our root end preparation appropriately and to match the genuine anatomy present. With ultrasonics, we also have the advantage of removing a smear layer, and we can control our risk of perforation as well. With microscopy, again, it offers us an opportunity to really see what's going on. On the right-hand side, a pretty obvious fracture, but that's not always the case. We can see that we have some fine anatomy on the left-hand side, a situation where while the canal has been addressed, there doesn't appear to be a standalone mesiobuccal 2 canal. We do have an isthmus or a ribbon coming off of that mesiobuccal. And so we can pretty well confirm what the etiological cause of the persistent apical periodontitis might be in this case, and treat it appropriately with the ultrasonic. As far as root end filling material goes, the research shows that root end filling is maybe not the most critical change in our armamentarium. While amalgam has been unsuccessful, materials like IRM or zinc oxide eugenol do show some success. But ultimately, it's a huge step forward now that we're incorporating materials like MTA or bioceramics. They're much kinder. They have a very high pH. They're radiopaque, and they're biocompatible and even bioactive, which allows for optimal healing. So this is just a general rundown of an endodontic microsurgery. In this particular case, I did have the advantage of direct visualization. This number 11 has a large radiopaque lesion, but bone is intact. You can see that I switched between a submarginal and a subcrestal incision, the intention being that I did not want a collar of unsupported periodontal tissue around the neck of that number 11. And so as we enter in and I'm resecting this granulomatous tissue and this long-standing lesion, we can see that we do indeed have a nice collar of healthy bone circumferentially around that number 11. So I'm not concerned about a root fracture in this case. It's more a situation of a long-standing infection. And so as we remove the granulomatous tissue, I'm doing a conservative resection of that root apex. And we're just trying to get things as cleaned up as possible so we can get down to healthy osseous tissue. And so while we can see a lot of hemorrhagic tissues present, once things are cleaned up, we can get hemostasis quite easily with bracelet pellets. As soon as we get rid of that granulomatous tissue, things calm down pretty remarkably. So here we're just staining with methylene blue stain. And this is just going to give us an opportunity to make doubly sure that we don't see any evidence of a fracture or a crack in this tooth. And so after we rinse it, again, there's really no indication of a vertical root fracture, certainly nothing that causes me a great deal of concern. And so moving on to a root end preparation, and with a little bit of time and patience, we can remove that pseudo-metallic material that was in this particular case. With a micromirror, we can see exactly how clean we have gotten our root end preparation. We know that we don't have material left behind. And now this is a root repair material by Brasseler. And once we place this, I tend to go back with a putty material, also a Brasseler root repair material. And then just using a series of placement and pluggers to condense it well. We'll move on with just giving everything a good rinse and evaluating the site. And we can actually see the implant at site 12. So right here, I'm just removing any material, any fibers from the bracelet pellets and giving everything a good rinse. In a case like this, I'm going to curette the osseous structure as well to reinitiate bleeding and then I go ahead and suture. I typically do not graft in these cases unless I have a through and through lesion. I just haven't had any issues with reformation of the osseous structure. We're dealing with a 4 or 5 wall defect. It typically doesn't succumb to any kind of a tissue ingress from the soft tissue. So, you know, from my perspective, I get good healing. It offers me an objective means of evaluating the patient's healing over time, and it saves the patient some money. In terms of prognosis, we have, again, a success rate of over 94%. Some would say it's higher, some would say high 80s. But the point is that we're dealing with a situation that is much greater in terms of a prognostic outcome than our traditional surgeries. And certainly in the realm of dentistry or medicine, we're dealing with a prognostic outcome that is comparable to anything else. When we look at this publication from the Colleagues of Excellence, which was released in 2010, we can see that in general, we have a great increase in success rate, the major focus being on the evolution in incorporating magnification and root end preparation with ultrasonics. So in terms of indications for root end surgery, there are a whole multitude of reasons why we might elect to go this case. If most importantly, we think that we're not going to be able to address it through traditional orthograde retreatment, that is a main indication. We could be dealing with a situation where we have aberrant anatomy, or we have lateral canals or ramifications. Could be dealing with bacterial infection in the periradicular tissues that would not resolve with a traditional retreatment. We also have situations where we have overextended material or extruded material. Could have a foreign body reaction as the main cause of this persistent apical periodontitis. And then of course, if the tooth has been previously surgerized, we know that we can surgerize it again with excellent success. Obviously, if we have an amalgam retrofill that we're trying to address, traditional orthograde retreatment is not going to work. And then of course, if we suspect a vertical root fracture, that is always a wonderful indication for us to do an apical microsurgery. If nothing else, we're performing an exploratory procedure. If we see a fracture, at least we've confirmed that. And then obviously, if we cannot determine whether or not we can improve the etiology with a traditional retreatment, surgery is a good indication as well. And this is oftentimes why I incorporate CBCT so heavily into my practice. I want to see exactly what's going on with that lesion. How is it shaped? Is there vertical bone loss? Is there an odd symmetry to the affected root apex? Are we dealing with multiple root apices that have a persistent infection or persistent PARL? All of those are questions I want to ask before I proceed with treatment planning. And of course, we could also be dealing with a true periradicular cyst. In situations like this, we don't have an opportunity to get a predictable resolution with traditional endodontic treatment. If the tissue is well organized and self-sustained, we're oftentimes not going to see a resolution, even if we do a perfect job with our orthograde retreatment. And then of course we have persistent causes of apical periodontitis. Nair pointed out, of the 6 listed, intraradicular infection is really the only source or etiology that we can readily address by retreating orthograde. If we have an extraradicular infection or foreign body reaction or some other issue that is in the periradicular tissues, that is where surgery is really key. We also have situations where biopsy is indicated. Again, a suspicion of vertical root fracture. If we have a lack of successful resolution following non-surgical retreatment, or if there's iatrogenic damage. all of those things can point us towards surgery. And so in general, if we're dealing with large posts, that's also another good cause. On the left-hand side, we see there's a large fiber post. It is borderline perforating the distal root. There's no apical, or rather, there's no radiolucency associated with that site, so we can assume that it's intact, but certainly we would want to be cautious about pursuing retreatment of that tooth orthograde and trying to retrieve that post. We could also be dealing with a situation like the center, and in particular the right-hand side, where it is a heavily restored tooth prosthetically. The restoration on the right obviously does not have a wonderful margin, but it's serviceable. There's no caries that's been present in this patient, who is 80 years old for 30 years now. And so it just doesn't behoove us to deconstruct that entire prosthesis and restoration only to retreat it. At this point, we're really looking at trying to maintain that tooth or moving forward with an implant, which the patient has no interest in. Of course, if we have a previously surgerized tooth, oftentimes we'll see amalgam restorations that have been placed. These are situations where, unless we can clean those periradicular tissues and re-prepare the apex of the tooth, there isn't going to be a predictable resolution of signs and symptoms. And then foreign body reaction or extruded material, periradicular tissue might be misbehaving primarily due to the extrusion of restorative material that we've placed. And so it behooves us to try to remove that physically. And in the case on the left, there are certainly situations where ideally we're going to be addressing this with both an orthograde and surgical retreatment. So sometimes combination is necessary. But this is a perfect example of cyst denucleation. We did biopsy this and it came back as a true cyst. This is a situation where, quite frankly, even if we addressed the mesiobuccal 2 in this case, and everything was treated to perfection from orthograde treatment, the likelihood that we would get a full resolution of this lesion, I think, is highly doubtful. In this particular case, we were able to address it directly. We're removing this long-standing infected tissue, and now we're down to good, clean osseous structure. And that just gives the patient a wonderful opportunity to heal instead of trying to resolve this lesion, this cystic lesion. The patient simply has to heal healthy tissue that has received minimal trauma. So then I wanted to talk about a couple examples, clinical situations from my own practice. This first patient is a 26-year-old female. She was a student at a local university. She had a really symptomatic case of an acute abscess with number 8 and 9. She was referred to a colleague of mine, a prosthodontist, for extraction and implant placement because these teeth are pretty heavily restored, and there was a lot of concern that they could not be readily retreated. And thankfully, the prosthodontist thought that there might be some other means of maintaining them. And so I had the pleasure of consulting with her, and it was determined that we would address these surgically. And so here is a before and immediate post-operative, and we can see that in general, we're able to be very conservative. We didn't have to remove a whole lot of the root length. We're able to predictably remove the obturation material 3 millimeters apically, and then we can get a good dense root end fill with an MTA material. Additionally, we can really visualize what's going on. We can clean the osseous crypt nicely, and we can spare the gingival tissue. As we'll see here momentarily, we get excellent healing, and aesthetics are not a concern with the healing process in these cases. So here in the immediate post-operative film on the right-hand side, we can see that everything has been well filled retroactively. And then in just 4 months, we have a marked improvement in the periosseous tissue, or rather the periradicular osseous tissue. And at 4 months in the lower picture, we can see that the gingival margins actually look improved on 8 and 9. And there is minimal scarring present, certainly nothing that would be noteworthy upon smiling. So again, we can wind up with a beautiful aesthetic outcome. Doing apical microsurgery in the anterior really is not a concern for me. I'll typically just do a subcrestal incision, and I'll scallop it so that I can reference the flap when I'm making my sutures as well. And that just allows for a wonderful outcome aesthetically. We could be dealing with a situation like this case where an endodontist was able to find MB and MB2. There's no lesion associated with the palatal or distobuccal roots, but we still have an issue with that mesiobuccal root. And so in this particular case, I'm suspicious that we have some kind of an isthmus adjoining those two canals on the mesiobuccal root. And so we did elect to proceed with surgical treatment. And in general, you can see in the post-operative films that the general contour of that root and fill is much more in tune with the general shape of the mesiobuccal root apex. And so in just a short 11-month period, and certainly sooner, we probably saw wonderful reorganization of the periradicular tissues. There's no indication of infection or persistent irritation at that site anymore. This is an interesting case because the patient has a long-standing history of temporomandibular dysfunction. In this particular case, the patient had been treated by an endodontist at a time when number 19 was effectively decoronated. Even at that time, following 2 jaw surgeries, including artificial temporomandibular jaw joints, the endodontist was unable to locate and negotiate the mesiobuccal canal due to the limited opening available. And now we're dealing with a situation where there is a recurrence or persistence of infection, and we're dealing with a situation where now we have a large zirconia crown and a few fiber posts that have been placed. And if we look at the CBCT, we can see evidence of vertical bone loss on the distal root. We can see a lesion associated with the mesial and distal roots. And we have an unaddressed mesiobuccal canal. In this particular case, the patient cannot open predictably. We explain the shortcomings of trying to treat this tooth with apical microsurgery, but the reality is that with our current opening, retreating with ortho-grade endodontics and even attempting to extract the tooth and certainly trying to place an implant would not have happened without sedation and possibly jaw dislocation. So the initial step was to proceed with an apical microsurgery, and we just advised the patient that she may need subsequent treatment down the road. But this was our first attempt to address her infection. And so in this case, we have an immediate postoperative radiograph on the right-hand side. And then after just 3 months, we start to see bone filling in, and then a reorganization of the periodontal tissues at 6 months. And then at 12 months postoperative, we see an excellent resolution of the radiolucencies at the apices. And so I always like to do a follow-up CBCT over time. Again, I like to hold myself accountable and really evaluate what's going on with the healing. Have I addressed the etiology? And we can see in this case that very clearly we have a resolution of the periradicular infection, presumably at least the periapical radiolucencies, as well as the vertical bone loss associated with that distal root. And the patient is asymptomatic, going on 2 years now. We have cases like this all the time where a patient has had prior endodontic surgery. This is a case where endodontics had been completed many decades prior. The apicoectomy that was completed was only about 10 years old, but it is a traditional style of macroscopic apical root end surgery. And when we look at the film here, we can tell again, just based on the radiopacity and the behavior of this root end filling, that we're dealing with an amalgam root end fill and a key slot preparation, or at least an incomplete resection of that root apex and a persistent lesion. In a case like this, I don't get overly excited about the potential of a root fracture. I do evaluate the bone carefully. And if we look here on the buccal aspect, though thin, there is intact buccal bone. So we do have a collar of buccal bone over 3 millimeters in dimension circumferentially. And so in this case, on the left-hand side, we can see as soon as we access the osteotomy and reflect the tissue, we can see the stained tissue from the amalgam root end fill. We can actually see the amalgam root end fill floating in our osseous crypt. And so after we clean everything in our intraoperative photograph here, we can see that now we're dealing with healthy, clean tissue, a clean resection, and a good solid root end filling using a bioceramic material. And so here we have our preoperative and immediate postoperative radiograph. And after just 4 months, we see a marked improvement of that periapical radiolucency. And then if we look at the CBCT, we can confirm we have reorganization of the periradicular tissues. The periodontal ligament now is present and reformed around the apex of this tooth. And again, the patient is asymptomatic and functioning comfortably. And then we have situations of unaddressed anatomy, and not necessarily anatomy that is readily addressed in the first place. This patient works in a dental office, had been treated by a very skilled endodontist, and yet we see a persistence of infection associated with the mesiobuccal root. We can see that there was an attempt at some point during the procedure to trough and explore for a standalone mesiobuccal 2 canal. But looking at this radiograph and the CBCT, we can tell that we're dealing with a situation where the roots are relatively narrow and we're probably not dealing with a standalone mesiobuccal root, or I'm sorry, mesiobuccal 2 canal. Additionally, when we look at this, we can see that we have an off-center canal here. We're probably dealing with a bit of an isthmus or a ribbon. There's no lesion associated with the distal buccal or palatal, so I'm not overly concerned about contamination of the root canal system. And we're dealing with a situation as well where the roots are relatively narrow and we're quite close to a strip perf. So I would be less inclined to retreat this with orthograde retreatment, in part because we're dealing with a situation where a strip perf could occur. And in general, we don't have a lot in the way of vertical bone loss. So I am pretty confident that the tooth is structurally sound. When we look at the root end after resection, we can see that we are indeed dealing with some kind of an isthmus coming off of that mesiobuccal. And there's likely some sealer here, but it's not as well addressed as we would ideally like, or at least as well addressed as the body would like. This is a different case, but a similar situation where as we stain, we can see quite clearly the addressed mesiobuccal root canal, but not necessarily a standalone mesiobuccal 2, instead an isthmus or a ribbon present. And so with root end surgery and an ultrasonic, we have the opportunity to root end prep the mesiobuccal root. We can address this isthmus and we can shape our preparation to match the natural anatomy and contour of that canal system. And again, with micromirrors, we can evaluate and make sure that we have a good, clean root end preparation. So in this particular case, we completed an apical microsurgical procedure. Our immediate postoperative radiograph shows us that we do have quite a high ceiling on our maxillary sinus. And what's interesting is as we transition now to the 3-month film, we can see we have a reformation of that maxillary sinus floor. And again, progressively at 9 months, until we look at our preoperative and postoperative CBCT, there's a pretty marked difference in the formation of that maxillary sinus floor. So we certainly were dealing with a situation that was long-standing and has resolved beautifully following surgery. The last thing that I'd like to talk about is a novel light source. This is an augmented visualization mode that is offered by the Xtara 300. I really enjoy this particular light mode. It's used specifically for caries detection. What I have noticed in my own personal application of this technology is that it allows me to differentiate well between natural tooth structure and osseous structure. And so, as we'll see in a moment here, we can use methylene dye, but independent of methylene dye, and that is not a necessity for this technology to work, we see a wonderful fluorescence of the natural root anatomy as compared to the surrounding osseous tissue and soft tissue. And so it really is nice for not only seeing great detail in the root anatomy, but it also offers a wonderful opportunity to distinguish where that root anatomy might be present. So as I'm making a root end resection, I can evaluate the osseous crypt for any retained root material, make sure that I don't have any root apices left behind, meaning I didn't section it and leave the very end of the root apex behind. So it really is a nice adjunct, I found. In terms of its application, again, it is entirely intended for caries detection. It doesn't require any kind of a spray or a liquid application. So if I'm evaluating a patient's tooth, this gives me an opportunity to look for caries and to make a determination about cause. And then I have all of my citations and sources attached to this particular presentation. If you have any questions for me about anything that I've talked about or anything off topic, any comments, please don't hesitate to reach out to me. I have my email address attached here. I also have my tag for Instagram. My hope is that I can post a good bit more surgical information, a lot more surgical cases. I tend to see a great deal of root end surgical cases. And so I'll be posting follow-ups as well.
Thank you, Dr. Irelan. We do have some questions, but before I get to those,
Okay.
I'd like to remind viewers to use the question box in the control panel to ask any questions you have. First question, when you are seeing a patient with a previously treated tooth, how do you structure your consultation to determine orthograde retreatment or surgery?
So whenever I'm having a consultation, it's usually pretty comprehensive. My consultations typically last 30 minutes to an hour. I'll oftentimes take a CBCT, but especially when we're talking about a previously treated tooth, I always take a CBCT, and I'll discuss that with the patient on a large screen right there in the operatory. And so when I'm doing a workup, I'm looking for things like vertical bone loss. I'm evaluating for, is there contamination of one root apex or other apices? Is there an asymmetry to the obturation in that particular root? Things like that are an important consideration for me. If I think that I can retreat it through orthograde means, that's always the first step. But if I'm dealing with a situation where the tooth may be compromised, a root fracture might be present, or oftentimes it's a heavily restored tooth, prosthetically speaking, I will err towards surgical treatment.
Okay, thank you. Second question, how often are you treating palatal canals on maxillary molars? Do you take a palatal approach, and how do you determine accessibility?
So actually, I do treat a lot of palatal canals on maxillary molar teeth. Oftentimes what I'm looking for is a general contour of the maxillary sinus floor. So it's not so much the buccal palatal distance that I'm concerned about. As long as it is shorter than 15 millimeters, I can comfortably treat it either way, spanning from the buccal cortical plate toward the palate. But it really comes down to where is that sinus relative to that palatal root. If I see that the furcation is pneumatized, then that's a situation where I will do a palatal approach, but otherwise I just take strictly a buccal approach and I'll treat all three apices at that point.
Okay, what kind of post-operative complications or discomfort do you typically observe? Do you give antibiotics? How do you structure post-operative appointments?
So typically post-operative discomfort is negligible. If there is significant swelling with the case when I'm consulting, I'll typically err toward the prescription of an antibiotic. That just helps the patient to be more comfortable during the procedure. It also offers me more flexibility with retraction. If there is an acute apical abscess, it can be a little problematic with that swelling. So once the patient is comfortable, I will go ahead and complete the procedure. I rarely prescribe an antibiotic after the procedure unless we are dealing with some kind of an acute infection. Then in certain circumstances, if the patient has poorly controlled diabetes or some other systemic health concern, then I might err toward an antibiotic. But typically, I'm just prescribing chlorhexidine mouth rinse twice a day for the first week. And then I have the patient come back a week later, and I just provide my patients with my personal cell phone number, and I give them a call for the first few days until I'm sure that they're in the clear.
Excellent. How do patients tend to respond to a surgical recommendation?
Oftentimes patients are open to the idea, probably more open to the idea than I would suspect initially. But again, it goes back to having a thorough discussion with the patient, talking to them about what we're seeing on the x-rays, what our goal to remedying the situation is. I do see a lot of dental and medical professionals in my practice, but there are a lot of lay patients as well. But if you explain to them what you're seeing and they can see it firsthand on the film, and you explain why that issue is present and why going with an orthograde approach will not address it and how a surgical approach very well could address it, I very rarely meet resistance on that point. And oftentimes I'm doing surgery that same appointment, even though the patient coming into the consultation had no idea that surgery was even on the table.
Okay. One more question. What features, if you can review, do you find beneficial with your microscope during surgery?
So I really like the onboard camera. That's a huge component for me. All of the videography and photography in this presentation, at least the clinical photography and videography, was recorded with the onboard camera. It doesn't dim my light source like a beam splitter might. It's great for a discussion with the patient. I have an unusual number of patients that want to see the surgery either live or after the fact, and I like it for communication purposes with referring dentists. But the ergonomics are really key. Besides the light sources, the augmented visualization modes, like that fluorescence mode, I really enjoy the foldable tubes and the more interface. I happen to see an older population. I can count the number of sub 25-year-olds on 2 hands that I see in a year. I'm much more likely to see an 89-year-old. And so, you know, for folks that can't be in an odd position, even laying on their side isn't an option. Being able to maintain proper ergonomics, to be comfortable and to visualize what I need to visualize is key for me.
Excellent. Well, that's all. We have all the questions. Thank you everyone for your questions, but we've run out of time today. So if we did not get to your question, we will answer it after the webinar via email. Be sure to take the free CE quiz associated with this webinar. Shortly, we will send you a recording of this presentation and instructions on how to access the CE quiz. Thank you all again for attending, and a special thank you to Dr. Irelan for your very informative presentation, and to our sponsor for this webinar, Carl Zeiss Meditech. Thank you and have a good evening. Stay safe, everyone.
Thank you.